All right, thank you everyone for joining us for today's session, MACRA, Accelerating the Move to Value-Based Healthcare. My name is Vicki Joyce, and I'll be your host for today's session. And we are very excited to have as our guest today to provide this information on MACRA. It is my pleasure to introduce Kelly Whittle with Whittle Advisors. Ms. Whittle is a passionate strategist and expert in change leadership. As the founder of Whittle Advisors, she shares client successes through international speaking engagements and publications. Her experience includes expertise in strategy, change leadership, and solution implementation for hospitals, physician practices, as well as specialty groups. She has more than 20 years of leadership experience and specializes in developing business strategies based on data-driven evidence. Whittle Advisors clients have been recognized nationally for outstanding ICD-10 transition achievements, and Kelly is also a founder of the International Society of Digital Medicine, which is focused on international collaboration to improve healthcare outcomes through the use of technology. Thank you so much for being with us today, Kelly. And with that, I'll go ahead and turn it over to you.
Thank you, Vicki, for the kind introduction. Welcome, everyone. This is Kelly speaking. I'm excited to join you today about our topic, MACRA, Accelerating the Move to Value-Based Healthcare. I have some late-breaking news I'll share in a subsequent slide. But as we get started today, we'll be talking about the MACRA regulation, the objectives of the regulation, and some key components to help you get started in developing your own unique strategies to become compliant. I'll also provide insights on how MACRA fits into the healthcare industry's transition to value-based healthcare. So be sure to grab your pencil or stay close to your keyboard so that you can jot down those questions or enter those comments into the chat section that Vicki referred to. Now, many of you are familiar with the term value-based healthcare. Today, I've brought along a quick description to help us sync up our references. As you know, the U.S. healthcare industry is in transition because we are finding ourselves in a healthcare system that's too expensive, too inefficient, and the quality is too varied. The goal you might often hear as being referred to as the triple aim. We're headed toward aligning the patient, the payer, and the provider to achieve better patient outcomes at a reduced cost with improved population health. Our real challenge here is that there will be less money to achieve greater outcomes, which requires a brand new business model. The breaking news is that providers have been committed to the transition in an unexpectedly successful manner. And so what that means is that when CMS put out the final rule of MACRA, CMS proposed that MACRA would impact 600,000 providers across the nation, and that 2/3 of them would be impacted by a segment of MACRA called MIPS. However, we found that today they've released that over half, 360,000 clinicians will be participating in 4 different alternative payment models. And we'll get into what MIPS and alternative APMs are, alternative payment models are, a little bit later in our discussion. The real key here is that clinicians are embracing the transition to value-based care. So if you have not embraced the transition yet, or if your organization is still in the fee-for-service mode of doing business, here's the key, that your peers are racing toward value-based healthcare in a way that even CMS did not expect. We're seeing that of the 360,000 clinicians participating in these alternative models, they'll be serving over 12 million Medicare beneficiaries. We'll get into more details about why this is significant as we walk through our time together today. So let's get back to those 3 truths of MACRA. The first truth about MACRA is that it's not an isolated program. You now know by my breaking news that CMS is serious about transitioning from fee-for-service to value-based healthcare. CMS is not the only payer that's serious. We're also seeing commercial and Medicaid embracing value-based healthcare models as well. MACRA definitely fits into this broader CMS strategy. It's aligned to bring our medical practices and our providers that are billing in Medicare Part B professional services into association with already existing value-based care programs. The second truth about MACRA is that MACRA is not business as usual. You cannot pick up your fee-for-service business model and apply it to value-based healthcare and expect to hit the quality, cost, and outcome measures successfully. It just doesn't work. It would be like the proverbial round peg in the square hole. We need to transition away from fee-for-service and quantity-based reimbursement to quality-based reimbursement, and that takes a completely different approach to doing medicine. In fact, I brought along a mental picture for you. I ask that you imagine with me, if you will, a person, a business person, standing with one foot on a wooden dock, and we'll call that wooden dock our fee-for-service business model. And the other foot is in a rowboat or canoe, and we'll call that boat value-based healthcare. Today, many of us standing between these two business models will find that the majority of our body weight is still reliant on that fee-for-service wooden dock holding us up, while our toe or our foot is just touching this area of value-based healthcare in a way that's not really risky. The problem is that what we don't see behind us is that the wooden dock is actually on fire. In the consulting industry, we call this the burning platform. Fee-for-service is definitely on fire, and our time to rely on fee-for-service is quickly dwindling. In my example, before CMS's announcement today, I had estimated that the industry has until the end of 2019 to rely on fee-for-service payments. That could be accelerating now that so many of the providers impacted by MACRA are making this aggressive shift, really pushing them into alternative payment models here in the first year of MACRA transition. You might already be aware that in 2020, hospitals will be accountable for cost overages that are associated with bundled payments. So that was one of my reasons that I was saying we can rely on fee-for-service until the end of 2019. We'll have to watch the industry to see how quickly the industry is aggressing toward value-based payments. You might not have that long. The third truth about MACRA is that MACRA is not a technology task. You will not find success by ticking off a list of to-dos or ticking off a list of capabilities associated with your technology. Now, don't get me wrong, we are required to have a certified EMR or EHR as the foundation for the transition, but the technology will not get us to the success line. We must also be able to document the clinical care that's being provided in a robust manner, access data analytics for reporting and continual improvements, and then have a repeatable framework to make continual improvements across our technology, our operations, and our reporting capabilities over time. So technology alone won't get us there. Now that we've talked about what MACRA isn't, let's hone in for a few moments on what MACRA is. I've broken out the who, what, when, how, and why, if you will, of MACRA at a very high level. MACRA impacts physicians, physician assistants, and nurses that bill Medicare Part B. This is the reason you'll hear me refer to MACRA's impact on providers. It's much broader than physicians. We are moving from fee-for-service to value-based care. This program started on January 1st of 2017, so we're a whole 19 days into the program already. But payments will not be impacted until 2019. And I want to caution you there. What you do in 2017 will impact your payments in 2019. You don't want to wait until 2018 or 19 to get started. You'll have to take action this year to avoid a 4% penalty in 2019. MACRA is composed of 2 tracks. You might have already heard these terms in the industry, MIPS and APM. And we'll talk about specifically what each of these tracks mean and how providers will determine if they're eligible and how one should determine which strategic track to focus on as we get started. I think it's interesting that CMS tells us that one of the objectives of MACRA is to reduce the administrative burden for providers as we move from fee-for-service to value-based healthcare. So what CMS is saying is that over the next several years, if you participate at a great level, you have the option of earning rewards for your participation. If you don't fall in line with our transition pace, there are penalties that are associated with your failure to transfer to value-based care. So it's the carrot and the stick approach to making this transition. Now certainly MACRA stands for the Medicare Access and CHIP Authorization Act, and it actually replaces several existing regulations that we have been working through over the past few years. The Sustainable Growth Rate formula, you might remember that. That was an annual increase in provider payments associated with a complicated mathematical formula. We didn't ever know as an industry, are we going to get 2% increase or perhaps a 7% increase? We're almost always guaranteed that it wouldn't be enough to cover the expenses associated with the care that was being provided. So a replacement of sustainable growth rate, most in the industry would feel is a positive. But it also impacts several other existing programs like PQRS, and it does have an overlap and what some in the industry believe will be an ultimate absorption of meaningful use. We'll have to watch that to determine if that really happens. MACRA sometimes is referred to as the Quality Payment Program. CMS has a program name, and you can certainly Google Quality Payment Program and get some insights and some tip sheets and educational material. Or you can Google MACRA, and CMS certainly has websites associated to the MACRA regulation as well, containing those awareness type resources. Here's a pictorial image of MACRA, 2 tracks, MIPS and APM. What I haven't shared with you yet is that under APM, there are 2 additional breakouts. So let's start with MIPS. MIPS stands for Merit-Based Incentive Program, and is designed for providers that are right now participating in traditional fee-for-service Medicare. It provides an opportunity to earn a bonus, and you can report out as individuals or as groups. APM stands for Alternative Payment Models. AAPM stands for Advanced Alternative Payment Models. And this is an option to earn a Medicare incentive payment, which is actually higher than the first-year bonus offered under MIPS. And there are other benefits associated with participating in APMs, and we'll walk through that information today before we're finished. Just remember that APMs are alternative business models, and MIPS are more geared toward reporting quality outcomes and getting our providers used to thinking about outcomes and reduce costs. A reiteration that CMS is no longer measuring quality and resource utilization as isolated projects. We're really honing in and moving into a deeper phase of value-based care, taking into account preventive care measures as well as a provider's ability to engage our patients. This all is leading us to be, as an industry, it's leading us to handle the care of our population. So we're moving from fee-for-service to value-based care and ultimately to the management of the care of the whole population, one step at a time. I do want to point out that all physicians participating in MIPS will have an official MIPS composite score posted on the Physician Compare portal, which means that individual providers will be ranked nationally against their peers. Some key dates under MIPS. we began at the beginning of this year, and 2017 is referred to as the transition year. You have until March 31st, or the end of the first quarter of 2018, to submit your data for the transition year for the first year. I encourage you not to wait until the first quarter of 2018 to think about your data, but to develop a strategy for monitoring your data and making improvements so that by the time you get to your data submission, you're actually submitting the best quality data that you can. And then payment adjustments, whether those are rewards or penalties, will begin in 2019. You might have a question about whether you're eligible or you're not eligible. The criteria for eligibility is that the identified providers here on the left-hand side of the slide are eligible to participate, but they don't automatically have to participate. So for example, if you are less than 1 year a newly enrolled Medicare provider, you are out and you are not eligible for MIPS. You're also out if you bill Medicare Part B $30,000 a year or less and you serve 100 or fewer patients per year. You are eligible if you bill Medicare Part B more than $30,000 a year and you serve more than 100 Medicare patients per year. So those are the criteria for MIPS eligibility. On the slide, on the right-hand side, I've also given you a look at the Advanced Alternative Payment Model eligibility. You are not eligible for those programs if 25% of your Medicare payments or 20% of your patients are not being served through the Advanced Alternative Payment Model. So we'll touch on that again under the APM section. I just wanted to show you the criteria here in comparison to MIPS. Now, under MIPS, there are 4 performance categories. This is where we can become really strategic in designing our transition plan. With the 4 different categories, each in the transition year is weighted at a different weight. So obviously, there are some that will be prioritized over the others. The categories are quality, cost, improvement activities, and advancing care information. Quality is actually worth 60% of the weighted score in the first year. Cost is valued at 0% of the weight. And you might think, well, gee, then we're only being scored on 3 categories. So while that's true, you can't discount this category called cost, because CMS is going to use the data that is gathered from your claims during 2017 to establish a cost baseline for the care that you're providing Medicare beneficiaries. You can't ignore costs this year, but just know that it will not impact the composite score. Improvement activities is weighted at 15% and advancing care information at 25%. Now, at Whittle Advisors, our research shows us that there are 2 categories that are more important than the others or should be prioritized above the others. And we find those to be quality and cost for these reasons. We believe that quality and cost will differentiate middle and bottom tier performers. Quality, which is the most heavily weighted component in the first year, will differentiate our middle and bottom tier performers. So if your strategy is to remain neutral in this first transition year and you want to avoid getting a penalty, then I recommend you focus all of your strategy and all of your energy on performing well under the quality component of the MIPS criteria. If you want to set a strategy of receiving a bonus, then you'll need to focus not only on quality, but also on cost. The reason being that after the first year, cost will differentiate our top and middle tier performers, and it is the top tier performers that will be eligible for a bonus. Our middle tier performers would remain neutral, and of course our bottom tier performers will be those that receive a penalty. Remember that MACRA is a net neutral revenue program, meaning that the penalties at the bottom will be used to cover the bonuses at the top. Now, cost is a much more difficult category or component to control. It doesn't take much experience in the healthcare industry to realize that hospitals and practices often have little ability to understand what the true cost of care is for their patients. The business model just didn't require that we understand cost at the individual transaction or individual procedure level. So moving from fee-for-service to value-based care, cost is going to be the most challenging for our business model to secure and measure moving forward. If you want to perform at the highest rate, really start to hone in on cost. Now let's talk about these penalties and rewards. The very first year of receiving a performance differential or additional money or a penalty is in 2019. We know that. That's well established. What we might not realize is that the income gap widens to 16% in that very first payout year between the high and low performing providers, and 16% gap is huge. Many of our providers working in independent practices or small group practices will know that they don't have margins anywhere near 16%. Well, by the time we get to 2022, which MACRA defines our progression from 2017 all the way through 2026, by the time we get to 2022, the regulation doubles the income gap, moving us from a 16% gap to a 36% gap between those that are top performing and those that are low performing. So definitely MACRA is something worth developing a strategy and beginning to prepare for. Now, one of the complexities about the MACRA regulation is the number of options that you can choose and the strategic decisions that you need to make. You'll recall that I've already mentioned if you don't participate and you take no action in 2017, you'll definitely receive a 4% penalty in 2019. But what we haven't talked about are the options for the level of participation. So if you want to participate at what they're referring to as MIPS test level, it means that you're going to submit some data with a target of remaining neutral in your payments or accepting a small penalty. It requires that you deliver one quality measure, one improvement activity, or 4 or 5 advancing care information measures. So very little effort, a one-time data submission. If you would like to avoid a small penalty and move into the possibility of receiving a bonus, then you'll need to participate at least at the MIPS partial level. This requires a consecutive 90-day reporting period, and you'll need to submit data from each of the 4 categories, which means strategically you'll need to start that 90 days sometime between January 1 and October 1, the start of the 4th quarter of this year, with a submission of your data by the end of the 1st quarter of 2018. Now, if you want to set your strategy high and go for the biggest bonus that you can, you would want to participate in MIPS at the full level, which means that you'll be submitting a full year of data. Let's take a look at the details associated with each of our 4 performance categories. This is probably the first slide in our conversation today where I've labeled it as a strategic alert. This is an opportunity for you to start to define your transition strategy, and you'll need to make decisions based on these 4 performance categories. Quality, as we know, is 60% of our 2017 score. But what we haven't talked about is that you need to submit 6 out of 300 quality measures. 300 quality measures is incredibly large. Not all of the quality measures will apply to each of our specialties that are impacted by MACRA, So you want to take a look at that list of quality measures and begin to comb through which quality measures your individual provider or group of providers will target to submit data or be part of. Remember that one of the outcome measures must be part of the 6, or you must choose a high priority measure. Not all 300 quality measures are created equal, so to speak. Some are weighted higher, some are high priority, some are low priority. Some are already tracking at a high level of potential success. So you'll want to take a look at the weight of those quality measures and really hone in on identifying the measures that you can potentially perform very well under. If I were developing a strategy for you, I would recommend that you choose 9 to 12 quality measures to target in this first transition year, which means that you would identify your quality measures, you would raise awareness with your clinicians, you would get consensus that you're tracking the right quality measures, you would begin to track your data progress, make recommendations on improvements throughout the year, and then be prepared to submit your data in one of the eligible formats. And so there's 3 ways that you can submit data under MACRA. One is claims data, which you don't need to do. CMS already has your claims data. The second is through registries. And the third option is through your EHR or your EMR. You want to align each of those data submission formats with your strategy under each of these categories. Cost, we talked about 0% of the weight in the first year. What you need to know is that as we move forward, we'll actually be tracking about 10 episodes of care. We don't know which episodes of care yet will be targeted in 2018. CMS is sharing that 10 episodes of care will be tracked to set the baseline in 2017, and that each episode will be worth 10 points. And you'll be ranked, your baseline metrics will be ranked with national benchmarks that will give you a composite score with a maximum of 100 points under cost. Now, CMS tells us that additional information will be forthcoming on this cost measure in 2017. So we'll have to keep watch to determine what additional clarifying information we'll receive regarding this important measure of cost. Improvement activities, 15% of your score, and this is actually an attestation. You'll need to identify 4 out of 90 activities that fall across 9 categories and be able to attest that you were active in these improvement activities throughout the first year. The final category is advancing care information. It's 25% of your score in the first year, and it's measuring your ability to engage with patients and to exchange information using your electronic health record or your electronic medical record. The key to remember is that there are 2 sets of measures that fall under advancing care information, and you'll want to pull the measure set that aligns with the year of certification of your EHR. So you were either certified in 2014 or your technology was certified in 2015. You want to make sure to align your target measures with that right set of certification measures. Lots of decisions to be determined as you begin to develop your strategy for meeting the MIPS qualification. This next slide shows us the calculation for determining your final score. We're not going to walk through the mathematics here, but I have listed it for your reference, for your future reference. I always find it important to understand what is the denominator and what is the numerator, how are the composite scores being weighted, where can I strategically make changes if I have limited resources and time to get the biggest bang for my buck. We hear from the regulation, it is currently speculated that the MIPS eligible clinicians will share in $500 million, at least in the initial years, as part of the bonus pool. CMS has established the bonus pool of $500 million. And that final score, final composite scores of greater than 70 points should qualify for a bonus. And the reason I say should qualify is that as your peers get better and they perform at higher rates, the entire curve shifts. So don't wait to get started. Those A students in our high school classes messed up the curve for all of us, and it's exactly the same competitive type curve here in the MACRA regulation. Now under MACRA, CMS has identified that we have patient-facing clinicians and non-patient-facing clinicians. And under this portion of the regulation, they've taken into consideration that both types of clinicians bill Medicare Part B for professional services. And if you're thinking, what's an example of a non-patient-facing clinician? A perfect example would be radiology and or pathologist. Now, MACRA participation is not limited to our patient-facing clinicians. Our RADs and pathos can participate as well. The key here to remember is that if you are filing under MIPS as an individual clinician, you must see at least 100 patients or more to be a non-patient-facing MIPS clinician and still participate. So you have to have a certain number of patient-facing encounters to qualify. There are many more areas of criteria that need to be met for groups that are filing under MIPS. And I encourage you to actually pull the regulation because you'll have to monitor not only the number of patients, but the amount of revenue that the group is incurring in order to be eligible as non-patient-facing clinicians. Another example of where the detail becomes important in the regulation is for our patient-facing clinicians. You might think of hospitalists or hospital-based MIPS eligible clinicians. Under the Advancing Care Information Performance category, we know that the ACI is all about technology. Well, hospital-based eligible clinicians don't necessarily control or have significant influence on the technology that's chosen and operated within the hospital. So what the MACRA regulation has done is allowed for a hardship adjustment to occur if you find that the technology that's being used in your hospital isn't compliant with the regulation. In 2017, you can apply for a hardship adjustment, which transitions the 25% weight of the ACI component to the quality portion of the composite score. So instead of 60% quality weight and a 25% ACI weight, in essence, you would end up with an 85% quality weight if your hardship is approved. Something to remember as you start to move through your strategies is that you have an opportunity to really hone in and still be part of the MACRA regulation. I brought along another example of how MACRA can impact our operations. There's definitely a potential for impact for those that are doing split billing. And so be aware of your existing billing strategies and arrangements. Here's a perfect example. A radiologist who qualifies as a MIPS eligible clinician that furnishes interpretation and reporting, this is the professional component for an X-ray service, in partnership with an X-ray supplier, might find that their claims are not eligible for the bonus or subjected to the penalty, and it could ultimately impact their overall eligibility if they're not billing more than $30,000 and meeting the needs of the patient count. Remember, that was 100 patients. You'll want to take a look at those three billing options. You know that suppliers have the option of billing a combined technical and professional component, or you can have a different strategy where the supplier is billing the technical component and the radiologist is billing the professional component. I've given you some additional data pulled right out of the Federal Register, answering the question about professional component billing. And the key here is that those services that are supplied by suppliers are not MIPS eligible for payment bonuses or payment penalties. So review your strategies around your billing structure to be well aware of this potential impact. Now let's level set for a moment. We're about halfway through our time together, a little bit more than halfway through. And we started with an understanding of what MACRA is and that there are two tracks. We've talked all about MIPS. We know that MIPS is a merit-based program designed for individual providers and groups that are still operating in fee-for-service. There's an opportunity to earn a bonus or a penalty, and that first-year bonus opportunity is equal to 4%. The other track is called the alternative payment model, and there are two sections under alternative payment models. One is referred to as the advanced or AAPM, and the other is MIPS APM. I'll talk to you here in a few moments about MIPS APM, so let's start with AAPM. The advanced alternative payment models provide a lump sum payment to providers of 5% at the beginning of a calendar year. That's very exciting because the 5% annual lump sum payment obviously is way higher than the maximum amount of bonus associated with MIPS. And as we move through this section, you'll see that participating in an alternative payment model is less tracking and reporting requirements than participating under MIPS. So there's definite advantages to participating in APM. Now there are certain thresholds of quality that have to be met, and we'll talk about that as well. Providers that participate in APMs that identify what those thresholds are and for some reason fall below the thresholds of qualification would end up in MIPS APM. So the MIPS APM is a second phase or second opportunity to benefit from an APM if your initial foray doesn't go so well. Let's take a look at some APMs. In this transition year of MACRA, advanced APMs are those that take on two-sided risk arrangements. Really important to understand that if you're going to participate in an advanced alternative payment model, you must take on risk for the overages. And that risk can be as high as 8% of the total in overages. Here's a list of approved advanced APMs under MACRA. We have the comprehensive ESRD model, the CPC Plus, which is our primary care model, and based on today's CMS announcement, we already have over 2,800 primary care providers signed up to participate in the CPC Plus here in 2017. If you're not familiar with CPC Plus and you're a primary care provider, the key to understand is that while you provide services in this transition year, you would continue to receive your fee-for-service payment and be eligible for bonuses. Something to take a look at. The Medicare Shared Savings Program, both Track 2 and 3, have a two-sided risk arrangement, and so both are eligible as AAPMs. The Next Gen ACO model, as well as the Oncology Care model. The key here for AAPMs is that there's a two-sided risk arrangement. Remember, as we move from fee-for-service to value-based care, providers must take on risk associated with cost overages and patient outcomes. There's no other path to reaching the finish line. Now let's take a look at the benefits and criteria of participating. The first benefit is that you're excluded from MIPS. MIPS is complicated. You need a strategy to get started. You have to understand the timelines, the eligibility requirements, make decisions about individual reporting versus group reporting. You'll need to understand which data gets submitted in which of the formats. Either you're going to meet it through claims, EHR, or data registries. All of these decisions should be made in advance, and then data should be monitored throughout the year to be able to perform well under MIPS. It's a high-touch, high-resource utilization program. APMs, on the other hand, is a model that is already established with criteria that are established, and for those that are already involved in APMs moving to an advanced APM, you already have the ability to do the tracking and the feedback loop that's required to succeed. So if you're part of an APM, I recommend that you stay in the APM. It is your best chance at success. You do receive that 5% lump sum bonus, and then starting in 2026, your physician fee schedule incremental increases year over year will be higher than those that only participate in MIPS. And right now, those numbers look like if you're part of an advanced APM, the bump would be a 0.75% or 0.75% increase in your fee schedule. If you're not participating or if you're part of MIPS, it would be a 0.25% increase. It does require that the model be run on a certified EHR, that your pro fees are based on quality measures, and that you're tracking your measures and reporting data through the model, and that you're taking on that additional cost risk. To identify yourself as a qualifying participant in an advanced APM, a certain percentage of your Part B payments must be run through that entity. So remember, not all of the patients that you see in your practice will be qualified for the APM. That you must meet certain percentage payments and threshold numbers to be a qualifying participant. So there is some data to be tracked throughout the model year. The key here is that beginning in 2021, your percentage numbers, your threshold numbers or dollar resources can actually be reached through a combination of private, Medicare, and Medicaid payments. Very interestingly, as we see an acceleration that's occurring before the designated milestones by CMS, is that right now in 2017, the Primary Care Plus model that is available is already seeing in the state of Michigan a program participation by Blue Cross Blue Shield of Michigan, Priority Health, and Medicare. So we see that private and Medicare payers coming together to participate in these value-based programs right here in the first transition year. The criteria are the same, whether you're a qualifying model or a qualifying participant. Let's take a look at those threshold numbers. Here in 2017, what we see is that you must have 25% of your payments running through the model in order to qualify, 20% of your patient population coming through the model to be determined as a qualifying participant. In the event that you haven't reached 25% of your revenue or 20% of your patients, then you would want a Plan B. So the Plan B here is that if you haven't met the qualifications for an advanced alternative payment model, you still qualify for a MIPS APM. This allows you to streamline your MIPS reporting, and you develop an aggregate score for the APM entity, meaning the entire group gets one score. You don't end up with individual eligible clinician scores like you do as an option under MIPS. You have to have an alternative payment model agreement in place with CMS to participate as an APM, and you can't have a participation list of one. There must be more than one eligible provider in the APM in order for it to qualify. So you can't have an individual participant in an APM. And again, APM will base their payment incentives on performance in the two most important categories, cost, and quality. Can't get away from those two quality components. Now, to score in APM, the eligible clinician must be on an APM participation list by the end of the quarter, the first 3 quarters in 2017. CMS will take snapshot data on the last day of each quarter of the first 3 quarters. So March 31st, June 30th, and August 31st. If you're participating in the APM, your name needs to appear as a qualifying participant on the participant list. Otherwise, you must go back to MIPS and participate in MIPS to avoid the penalty. Now, I mentioned that it's best to participate in an AAPM. In the event that the AAPM doesn't perform well, then you have the opportunity to file the data as a MIPS APM. And you can do that in these programs: the Comprehensive ESRD Care Model, Comprehensive Primary Care Plus, so that's our CPC Plus model, the Shared Savings, either Track 1, 2, or 3, the Next Gen ACO model, and the Oncology Care Model. And here again, it's all arrangements make you eligible as a MIPS APM. It's only the two-sided risk adjustments that make you the advanced APM. Now, some of you joining on the call today might be joining us from a health information management role. And the reason I call out the impact to HIM is that as we move from fee-for-service to value-based care, all of these quality measures, cost measures, improvement activities will be based on one thing, and that's clinical documentation. We established the importance of clinical documentation in the ICD-10 transition, and we're reiterating the importance of clinical documentation. So I have a recommendation for our HIM leads to begin to develop a culture of documentation excellence. Be sure that you're partnering not only with your providers, but with your quality teams and your business intelligence team. It'll be really important that each of these functional teams understand how the documentation is created, what the circumstances are for creating it, and that the documentation is robust enough not only for billing, but to be successful in reporting quality and outcome. After all, the goal is to be able to access the right information in the right place at the right time for the right patient. As we walked through the alternative payment model options, you'll notice that there are only 5 or 7 total APM opportunities for this very first transition year. Some of you might be wondering, number 1, how can I participate? Number 2, is there an APM that's right for me? Well, the good news is that CMS recognizes that more innovation is required to be successful in our move to value-based care, and they've established a committee to review APM model proposals and approval so that as we move from 2017 into 2018 and 2019, we'll be able to accelerate our transition to value-based care. If you're interested in participating in the development of an APM, here are my 5-step process recommendations. First, you'll need to gather a committee of physicians to develop 1 or more APM. And the reason I use 1 or more is that we're seeing APM develop around types of care, so that would be specialty-based. We're also seeing APMs develop around the setting in which care is provided. Perfect example of that is CPC Plus, where our primary care docs are making changes to improve that triple aim. The second step here is to identify your opportunity to improve care and begin to document it, being sure to hone in on any barriers that exist in the payment system that would make it difficult for physicians to do something different when delivering patient care. The third step in my recommendation is to identify the payment changes that need to be met in order to overcome the barriers. So this is the real meat of your gap analysis and remediation planning. The fourth step is to analyze the benefits and make sure that the changes bring sufficient and significant improvements to patient care and savings for our payers. Doesn't make sense to do something different if patients are not ending up with better outcomes and the overall cost is greater. And then finally, document the design of your payment model and submit it to CMS's technical committee for review and potential approval. I will invite anyone who's interested in developing an APM to reach out to me. I'd love to get in on the ground floor of developing the strategy for these new alternative payment models. I encourage you to take action now that you've received a high-level overview of what MACRA requires. Start to develop your strategies and think about your transition to value-based healthcare. You'll want to complete a review of your current operational and analytical capabilities, honing in on the gaps that keep you from being successful under MACRA. Then develop your action plan. And finally, consider developing a relationship with a partner or a guide, especially in areas where internally you don't have the necessary skills and knowledge to be successful under the regulation. And as we prepare for Q&A time, I'll share my last thoughts on being successful under value-based healthcare. There are definite success levels or criteria to be thinking about as you build your strategies. The first, in order to be successful, you must have access to the right data in the right place at the right time and have automatically generated analytics. And so data and analytics is key number one. You must be moving away from manually created reporting and alert systems. Your technology must give you the analytics on demand or at a regular pace so that you can make continued improvements. You'll also want to think about the strategies that you use for transition of care. Remember, one of the real keys in value-based care is that we avoid high-cost care in the inpatient setting by providing appropriate care for patients in alternative settings, like the physician practice or an outpatient clinic. Keeping track of the care that patients are receiving across the continuum of care is a real challenge today. Interoperability of systems, lag of sharing patient service information, returning lab results and radiology results, all of these are barriers to being very successful in sharing transition of care data today. So think about, how do you communicate with those that are providing care upstream and downstream? And then finally, you'll need a repeatable process to improve over time. You want to improve your clinical care protocol adherence. You'll improve your clinical documentation, as well as continue to reduce costs. I encourage you to reach back to me if I can answer any questions or provide clarity and guidance on your transition to value-based care.
And I just wanted to take a moment to thank you so much, Kelly Whittle with Whittle Advisors, for presenting today's session. And for our attendees, if you have any questions or need assistance with your implementing MACRA at your facility, or if you have any other strategy needs, feel free to reach out to Kelly at the contact information listed here. And thanks to the attendees for joining us for today's session. We look forward to having you at a future webinar or event as well.
Healthier outcomes are now easier to embrace. We know you run a busy practice, and efficiency is top of mind. Discover 360 degrees of connection and support. Keep your practice on solid ground with a cloud-based EHR.
Care 360 offers a full and fully mobile EHR that helps keep medical practices efficient and profitable,
while connecting to the larger healthcare community.
Join the network of over 300,000 Care 360 providers in 90,000 locations and connect to other healthcare providers as well.
Coordinate care to and from anywhere.
Care 360 integrates providers and technologies across sites and care settings,
while seeing and sharing the bigger picture.
Care 360 allows you to send patient information using the CCDA industry standard format accept information from other providers, and access extensive patient lab histories to help optimize care.
Meet meaningful use requirements.
Care360 EHR is ONC certified to qualify for meaningful use.
While exchanging data simply and securely.
Physicians collect and share data with other EHR users to meet industry requirements with Care360 Data Exchange.
And with new Care360 Revenue Cycle Management, you can maximize collections and revenue.
Care360 provides you with a team of billing experts to take complicated billing issues off your plate, allowing you to focus on what matters most, your patients.
While reducing your administrative burden. And that means more time with patients. Care360 also offers many other great advantages. Boost patient engagement and compliance with MyQuest.
Patients can view and share vital health information with their healthcare providers.
Elevate patient conversations with interactive insights.
Enhance lab results with diagnostic insights, accessible in Care360 and to patients through the MyQuest patient portal.
That's 360 degrees of connection and support, and healthier outcomes for all. Care360.